Hello and welcome to HealthCast, the higher education healthcare podcast. My name's Lawrence Hill and I am one of the lecturers that work in the School of Health Sciences at UEA Norwich. Today, and on this episode of HealthCast, I'm very happy to say I'm being joined by Andrew O'Connell. Andrew is the LeDeR nurse for Norfolk and Waveney. And we're going to be talking about the LeDeR report, and we're going to be talking about a kind of a case study that we think that healthcare professionals will find interesting and maybe useful for influencing their practice.
Yep.
So let me tell you a bit about Andrew. So Andrew is a registered children and young people's nurse or paediatric nurse. He trained at the University of Hertfordshire and moved to Norfolk 6 years ago. Previous to nursing, you worked across a number of different healthcare settings, including improving access to psychological therapies and Tier 3 drug and alcohol treatment services. He's worked across multiple acute settings, including general pediatrics and Children's Assessment Unit, CAU, three-letter abbreviation that I wasn't sure about, and the neonatal intensive care unit. He started work in children and young people's continuing care 5 years ago and solidified his experiences of physical and intellectual disabilities, including publishing a literature review. And maybe we can stick a link to that after this for people to have a look at, in the Transition Care in Nursing Journal. So you took on your current role in January of last year. And you've been busy building and establishing LeDeR, and that's spelt LEDER, as a service within Norfolk and Waveney. Currently halfway through your master's degree. You're a busy man. In intellectual and developmental disabilities at Kent
University,
So there we are. So that's a kind of clinical professional background.
It's like a really terrible "This Is Your Life," isn't it? I just need one of those big red books.
Well, hopefully I last a little bit longer than dear old Michael Parkinson. But yes, so tell us a little bit about yourself. What did you do before you became a nurse? Like what were you interested in?
So what from a job point of view? Yeah. So I'd had a couple of different jobs. I never really had a very successful school career. From when I was younger, it was never really a focus of mine, to be honest. I didn't really find my feet with academia and academic work until I got to university, and I found something that I was really passionate about and I really loved. So as I say, I was kind of working in a healthcare arena with drug and alcohol services, so I was doing a lot in the way of sort of like health assessments, group work, therapeutic work, harm minimization, in the way of sort of like needle exchanges. There was lots of prescribing, so substitute prescribing for different addictions. So it was although I wasn't working as a registered clinician, it was a very clinical environment, supported by a lot of nurses. And I think I just came to the decision that it was what I wanted to do. I wanted to be a nurse. My sister is a nurse.
Shout out to sister. Shout out
to Jen. She's actually a health visitor, but she's worked everywhere, and so Jen was a bit of an inspiration. Oh, definitely. She's amazing. She does adults, but she's worked across sort of different surgical units, and she's worked over in Australia before sort of settling down and having kids, and decided health visiting fit from a work-life balance point of view. But so I decided on nursing. I did have a very brief a dalliance with radiography. I was thinking, maybe diagnostic or therapeutic radiography, and I did a couple of placements, like taster days, if you like, in different settings, but it wasn't really for me. I was sort of, nursing all the way. I kind of had my fill of mental health from drug and alcohol services, because that tends to be, the nurses that you find there, and I wasn't interested really sort of in adults, and so kids was where I wanted to be. At the time, going back, I'd probably do learning disability nursing if I could change things, but I must admit, going into it, I didn't really know about learning disability nursing, which is sort of something in itself, which is why the masters I wanted to really give myself a bit of a foundation in the the models of care, and which I've missed really, because mine's all been practical based learning since qualification.
Interesting. And so that's kind of like Andrew, the kind of clinician and professional.
Yeah, I wouldn't use those words, but all right.
It's really on a HealthCast. We really like to get a little bit of a feel for the person as well, behind the professional. So tell us a bit about your interests and your hobbies. What do you do when you're not the leader nurse for Norfolk and Waveney?
I'm a very, very old man, so I like gardening.
Very good.
I love, sort of being outside, pottering about the garden is a good sort of stress reliever for me, sort of very important from a well-being perspective. I love the beach. I love Norfolk. As I say, I mean, I came here when I met my partner, my fiance, and he's sort of Norfolk born and bred. And, as soon as I sort of moved in together, I felt like home. I love Norfolk. I love being near the water, the beach. So going to the beach with our dog. We've got a retired greyhound called Paddy, who is incredible. So we like taking him to the beach. So just being out and about, really.
Kind of like a kind of earthy, kind of nature, kind of connected.
Outside. I love being outdoors. I don't spend too much time sort of cooped in, which has been interesting. Sort of post-COVID, I tend to work from home a lot more than I did before, and that's an adjustment period, because I do like to be out. And if I'm stuck in the same four walls for too long, I go a bit stirk.
For raving. Sure. Well, don't we all? Okay, so let's move on a little bit. So we're here today to talk about the LeDeR report and how and why it's relevant to really all healthcare professionals, whether that's from paramedics to podiatrists or speech and language therapists to social workers. Clearly this report has value and for every professional group. So can you tell us a little bit about LeDeR?
Yeah.
Why did it come about, and what is it?
Yeah. So as I tend to start every sort of session that I do, LeDER's an acronym, obviously, in the NHS. So it stands for the whole title of the service, which is a bit of a mouthful, is Learning from Lives and Deaths for People with a Learning Disability and People with Autism. So it was set up, it first started really about 2016, but it has its roots much, much farther back than that. Many healthcare professionals, definitely all healthcare professionals, I would have thought, but certainly students will know about Winterbourne, and the real start from a public awareness point of view as to these healthcare scandals, abuse scandals of people with a learning disability and autism in secure environments or private hospitals. And sort of following on from that, there was a CPOLD report, which was the confidential inquiry into the premature mortality of people with a learning disability, I think is the acronym, but that was out in 2015. And that was essentially one of the first national looks at causes of mortality for people with a learning disability and autism. It may have just been learning disability at the time, but one of the main outcomes of it was we need a dedicated mortality review service.
Because there is a healthcare inequality there, isn't there?
It's stark. I think it was probably a lot more wide. It was a lot more apparent than anyone actually maybe thought about. So because of that, one of the recommendations was having a learning disability mortality review service, and so that was initially launched in 2016, and it's been through a couple of reiterations since then. Just after I came into post, there'd been a massive national policy change on how it was delivered, and that was partly informed by Oliver McGowan, who was a young man who had died, unfortunately, sort of prematurely due to the experience that he had with healthcare, and he had a LeDeR review which didn't quite come up to scratch, for various reasons, and that
What do you mean by that? Sorry, what do you mean he had a LeDeR review?
So he had a LeDeR review sort of pre-2021. Oliver McGowan was a young gentleman who died, and you may have heard of Oliver McGowan training.
Yeah. Oh, okay. So the LeDeR entity that did a specific investigation into his case.
Yes.
Right.
So they did a specific review because he was a young person with a learning disability who had died, and there were some real problems with that LeDeR review, the quality of the LeDeR review.
Oh.
How much its accuracy, and on the back of that, there was some real changes. How we structure, what our governance looks like, how we support transparency in how we review, how we're sharing information involving families in the review process. So there was a big policy change in 2021, and I sort of came in after that to set up the LeDeR service for Norfolk and Waveney.
Right.
Before then, it was, do I use the term afterthought? Probably not, but LeDeR reviews were very much part of someone's everyday job. So you could be asked to, have you got some time Tuesday afternoon? We need you to do a LeDeR review. Or, it could be shared out amongst a certain amount of people as part of their day-to-day job.
Rather than being a dedicated
service.
Specific service.
Yeah, with people who are used to doing healthcare reviews, who are used to assessing large amounts of quite complex clinical information, who have the skills and experience in learning disability or, in mental health. And what was needed, I think, was a real approach to LeDeR, which made it a quality service, really robust, and something that people could put their faith in. That there was going to be real actionable change, and there was going to be a fair and sort of transparent look at the circumstances around that person's life and their experience. And sort of that's where we are now, really. And that's what we've been building over the last 18 months.
So, I mean, I can see why you would have like all of these lovely kind of outdoor hobbies and stuff, because dealing with this stuff, I mean, clearly part of your role is about education and about sharing the work of LeDeR, but that must be really hard dealing with all of that information. How do you manage? I mean, is it hard, and how do you manage all of that difficulty?
No, it is, because unfortunately, the majority of the cases that we see problems. We see where care hasn't been ideal, and we see where access there have been barriers to accessing healthcare, where inequality has been very apparent. Where safeguarding has been an issue. So it's never easy. I think. I mean, all healthcare professionals, I think, come across, death at some point. Whether that's directly or whether that's supporting families. I mean, I'm really lucky. I lead the team, so I don't tend to do the reviews myself. I'm more of a sort of clinical supervisor regarding the reviews. I sign them off from a quality perspective. I do a lot of the learning interaction work, but I've got a really amazing team, all nurses across different specialties. So I've got learning disability, mental health, general acute, pediatric.
Can I just butt in there a second? And is there any particular reason why it's all nurses in the team? Is there scope within the structure of LeDeR for speech and language therapists or paramedics or other more midwives?
I mean, I think so. I don't. I'm trying to see I don't think there's a policy that states that the reviewers have to be nurses, because more than anything, it's about your knowledge and experience of people with a learning disability, supporting people with a learning disability, and the services in your local area. So I don't necessarily think so, because we have, as you can imagine, we have quite a few cases where there's, the person has had a lot of involvement with mental health services. That's not my sort of background from an experience point of view, the different sections, the different sort of holding, the different and complex medication regimes. But what we have is a mental health nurse in our team who, really has all of that background knowledge. Our learning disability nurse, and again, I'm PEDS nurse by background. She was a learning disability nurse in the community for many years. So we rely on each other from that peer support point of view. If we're doing a review and we've got a question, we go out to who we know in the team is able to support, and we've got a really strong supervision ethic, peer support ethic within the team, which you need, because as you've said, we are dealing with difficult things on a day-to-day basis. You're spending your working day trawling, looking through notes, speaking to often very distressed families, and it is emotionally taxing, and maintaining your well-being is really important if you're going to give everything that you can to that review and do the best job that you can. And part of that is how we support each other as a team. And I mean, I'm really lucky. I've got an amazing team, from our reviewers through to our administrator, who we always, she's the boss really. I just turn up. She runs everything. But in that point of view, we're really lucky. We have a really good team.
So this team,
environment.
this team, and that's obviously part of the support too.
Yeah.
So this team comes together. They do investigations. They do outreach work, presumably too, and they pull together these reports that are generated at a regional level that inform a national report as well. Is that right?
So every ICB, every Integrated Care Board, as they are now, has the responsibility to deliver LeDeR in some way. So every ICB will have that, and what we do in our team, so we do LeDeR for our integrated care system, so for Norfolk and Waveney. So every area will have a LeDeR team doing their reports. Now, where it might be a bit different is that in some areas you've got ICBs and sub-ICBs, and the organisation can get a bit complex. We're lucky in Norfolk and Waveney, we just have the one team, which is our team that does it for the area. I guess just as a clarification, what we don't do is we don't do an investigation, which we're quite clear about. LeDeR is in itself a quality improvement initiative. It's a quality improvement project. So we don't have any statutory powers. We can't, compel people to sort of speak to us or to provide evidence or, to provide their notes. I mean, we're really supported in Norfolk and Waveney, from, professionals speaking to us about their experiences, families speaking to us. We tend to get notes relatively quickly. We have really good relationships with the coroners, and when the medical examiners come into place, I think it's next year now, maybe. We have a really dedicated sort of system in Norfolk and Waveney to the work that we're doing.
But quite a lot of liaison then. So
yeah.
Quite a lot. Doesn't sound like you have to do too much negotiation, because it sounds like people are genuinely motivated to contribute and to improve the lives of people with learning disabilities and autism.
We're really lucky. We're really, really lucky in sort of the response that we've had from the system, because we're completely reliant on that to do our jobs properly. To do a sort of a really thorough look. We are reliant on the support from often stretched sort of professionals who have got their day-to-day job to do. So we're lucky in that sense.
So these reports in the end, not an investigation, but these kind of resources come together. And there was when was the last LeDeR report published for Norfolk and Waveney?
Well, so the last one that's been published would be last year's. But I have I finished our one for this year. So we tend to run on a financial year. So we'll go March to April. So I've finished now, it's all written, the 22-23 annual report, which is currently sitting with our boards, and it's going to be published hopefully by the end of this month, mid to the end of September. And then, there'll be a big drive, pushing it out across the system for people to sort of look at and reference.
And that is, I think, really key, isn't it? Because, we're hopefully people are listening in who are, healthcare professional students and healthcare professionals themselves. How does that LeDeR report relate to me if I'm a paramedic out there, if I'm a paramedic student, or a children's and young people's nurse, or a speech and language therapist, or a physio? Yeah. How does that report relate to me? What does it give me? How do I use it? Yeah.
Well, I think, it's a big document. It's 66 pages, and there's a lot of information in, but I guess from my point of view, the main thing I would like people to take away from it is just the understanding and the awareness of the experience of people with a learning disability and autism, how they access healthcare and the difficulties that they can face in accessing healthcare. So, I mean, for me, that's what would be important for me. I mean, even if we collect lots of data as part of our role. You know, how old people are when they died, what their cause of death were, where they died, where they lived. You know, what vaccinations they had, what screening programs they'd had. So we have a lot of data, and there's a lot of data in the report, which is really interesting. And, you know, I've done some analysis on that, which kind of shows where the inequalities are that we face. But there's one section in the report where essentially what we've done is given a sort of an overview of some of the different people that we've reviewed this year, you know, sort of a sample of what their review said about them and what their experiences were. And even if someone reads that section, I mean, I'm trying to think, is it section 10? I can't remember. I've been living with this document for so long. But I mean, all it does is it literally sort of gives you sort of in 3 paragraphs, I think there's about 6 or 7 case studies, just what that person's experience was and what the review told us. And even if you've got 5 minutes in your day to sort of read that, because actually that's the important bit. You know, LeDeR is about hearing people's voices, listening to people's experiences, and, you know, taking the learning from that. The data's great, and, you know, the NHS loves data, but it's that person's voice and experience, which is what gives a review, you know, the richness that we need.
The depth.
And
so
and
often,
the
isn't it? The qualitative components are essential for bringing home, you know, because you can look at mortality statistics and think, oh, yeah, that doesn't look very good. But then if you think, oh, this was, you know, we'll talk about a case study later, but, you know, so-and-so whose life was, you know, who died this early, and this was the experiences that they had prior to that point.
Yeah. They were a person with hopes, with aspirations, with the family. And it's really, really easy because we get so much data in healthcare, it's sometimes too easy to disassociate the person from that number or that statistic. So what was important sort of for me when I was putting together the report and deciding how we wanted the report to look was that, you know, it was really important to us that, you know, that we kept that voice, and it just wasn't, you know, however many pages of pie charts and tables, which there are a lot of.
And actually, it's probably worth saying that is important too, isn't it? Clearly, it's hugely important because I think, you know, for healthcare professional students listening, you know, clearly the narrative is essential for understanding the lives of these people, but understanding the scale and extent of a health inequality, whether that's, you know, in this case, with, you know, people with learning disabilities and autism, but it might be, you know, different kind of markers that, you know, we're seeing healthcare inequalities in maternal health, in minority ethnic groups compared to white populations, and understanding that there is a gap, and understanding that there is, you know, that gap isn't insignificant, and that actually maybe there are things that we can think about to try and close some of those healthcare inequalities, is perhaps initiated by the data and then carried forward by the stories.
I think so, because, you know, I think sometimes the short, sharp shock that comes with some of our statistics is actually what hits home. So, for example, you know, letting someone know that a person with a learning disability will, on average, die over 20 years younger than someone from the general population. The fact that you are 6 times more likely to die prematurely if you have a learning disability. In Norfolk and Waveney, one of our big areas that we want to work at is the uptake of pneumonia vaccines. So if you think nearly 90% of our of the people that died from pneumonia were eligible for a pneumonia vaccine, and you know, less than about 10% of those people had it. So 90% of the people that died from pneumonia who were eligible for a pneumonia vaccine didn't have it. And those sorts of figures are what hit home what we're missing. You know, what we're missing as a system, what we're missing as healthcare professionals. And so, no, that data is really important.
And so that's just a really simple, you know, that's a golden nugget there for anyone listening. You know, actually, if you are, you know, interacting with a service user with learning disabilities or autism, you know, inquiring about vaccination status isn't just about pediatric prevention of, you know, measles, mumps, and rubella. This is about actually, you know, do you know you may be eligible for this, and that might be beneficial.
So, definitely. You know, so much of you know, general public health which we all should be accessing. And cancer screening is another one. It's asking that question. We don't think about it because it's just part of, sort of day to day. I reach this age, I fit into this certain eligibility criteria, so I am eligible for this screening. But, our rates for cervical and breast screening are awful, sort of in Norfolk and Waveney.
Right.
Bowel screening is not too bad. But then if you can, so why? Why is our cervical and breast screening so much worse than bowel? And actually, it's less invasive. Bowel screening, I can do it at home. I can be supported in my home environment to do it. Whereas, cervical and breast screening is far more invasive. It's a procedure that, is involving going into a clinical environment, unfamiliar. And what you were mentioning, you mentioned earlier about other inequalities within the system, like, for example, people from ethnic minorities and, women's health, as much as we see inequalities in the general population, those inequalities exist within the learning disability and autism population as well. And that's where we start to see it, things like our screening programs. So it's really, really clear that we need to be so aware of what inequalities exist within the system already, and how are they further compounded when a person, has a learning disability and autism.
And so reading that report and getting a sense of where some of those inequalities might be, you know, per region, and a lot of our clinicians are practicing regionally rather than kind of in a wider sphere than that.
Yeah.
Understanding what some of the local challenges are might allow you to ask some more focused questions, perhaps, or
definitely
make some more recommendations.
Even so, something that we've been able to do this year, again down to the sort of the changes that we made with our post-review data collation, is around the where people live and how where someone lives and the indices of multiple deprivation. If you heard of it, so. Which is really amazing. I found out how to do this. You just need a postcode. You can look up, where someone's postcode corresponds to, their overall level of deprivation. And that's a mixture of health, employment, training, transport, all of those things. They sort of, come together. And most people with a learning disability, where they live, they are in the lower end of sort of the IND scale. So it goes from 1 to 9 0 to 10, sorry. So most people with a learning disability live in an area with a score 5 or less.
Right.
And that's about, so where are we, most people live in residential services, some type, whether it's supported living or whether it's a sort of a care home or a nursing home. Where are we commissioning these services? Where are they being built? Where are we providing sort of suitable accommodation? How easy is it to get to a GP surgery? What's the public transport like? How easy is it to get into town? What are the local services? And I mean, that really is, it comes into every part of health and social care planning.
I have to say, it becomes abundantly clear to me why this is very much a specialist role, and very much why it needs a dedicated service for actually people focusing on this. And it just makes me want to say really thank you again for coming in today and to talking about this stuff and to giving us this insight. So what should, or how should our students here at the, in healthcare education, how should they adapt to better support people with learning disabilities and autism? What should they do? They need to be aware of the data. They need to be alert of some of the reports.
Yeah.
But what can they do at a kind of an interpersonal or a kind of a professional or clinical level to really be a better clinician for people with LD and autism? Yeah,
and I think one of the main things that is about gaining that experience. So whenever I'm talking to any health or social care student, wherever they are, at the moment while you're studying, you're in a very lucky position in that there's some element of freedom that you can reach out of the placement that you're currently in. So if it's an ED placement, if it's a GP placement, community, what are the learning disability services where you are? Is there a acute learning disability nurse that you can shadow? Can you spend some time with a learning disability dietitian? Are you able to spend some time with the learning disability social work teams? Because that service is set up to support people with very sort of individualized needs, and they're set up to sort of adjust their practice to support that. And the big thing that people need to be aware of is about providing reasonable adjustments, which I'm sure is a term that most people would have heard. Which, I mean, it's...
What do they look like? What are reasonable adjustments?
Good question. A reasonable adjustment is anything. It can be anything that makes it easier for that person to access the health or social care that they need. And it's really, the way I see it is personalised care, which we do for everybody.
Yeah.
For a member of the general population that works 9 to 5 and they need an evening appointment, so the GP surgery opens later. That's a reasonable adjustment. So it's not just specific for people with a learning disability and autism. We make reasonable adjustments every day in how we communicate with people, in how we see that person might need a bit of extra support with this, or they're struggling with that. What we do find is when you move into supporting people with learning disability and autism, that maybe they can become a bit more complex, either because you need specialist equipment, you need specialist care plans, which people are less familiar with. It's less. We don't have that experience usually as professionals working outside of learning disability arenas. So
getting some kind of, just using a bit of initiative, maybe contacting any of those local services and saying, can I?
Yeah, if you're a student and if you're on placement, definitely. If you're, if you're practicing, if you're sort of qualified and out there and practicing, those services are there for you. And it's about being aware of what support services are available and how can they support me with the job that I need to do. Every healthcare professional, needs to do CPD. Nurses, we need to do it as part of our revalidation.
Paramedics, you've got to meet the standards of CPD for the HCPC. Ongoing development.
So why couldn't part of your ongoing development being, can I arrange a day with the learning disability nurses? It's not set teaching. It's not, an online mandatory training. But
and you don't have to become an expert.
No, not at all. But it's about that networking, that collaborative working, and just getting some real insight into how they work. So there are so many options which, people could explore, to better serve, the patients that they're dealing with. It's just about, as you've said, thinking outside the box.
Sure. Yeah. And talking of thinking outside the box, one of the things that we were talking about in preparation for creating this podcast was kind of bringing it home, wasn't it? And you talked about the value of stories, essentially the narratives in the qualitative report parts of the reports. Yeah. And so something that we want to do as part of this podcast is to present effectively a case study. Yeah. For people to think about. So we've been working on this case study as a collaboration, and what we're going to do is we're going to read through parts of it, and then I'll read a part of it, and then we'll get Andrew to kind of give us some insights and some reflections, perhaps on your experience, and maybe draw on a bit more of this conversation there. So here it is then. So a call is received from a supported living environment for Ali, who's a 50-year-old man with generalized signs of deterioration, a distended, painful abdomen and vomiting. He's got a flag on his address. This is kind of targeting paramedic students, really, I think, in this one. But he's got a flag on his address for a history of aggressive behavior, but not for his learning disability. He's known to have Prader-Willi syndrome, type 2 diabetes, and a mild learning disability. Mm-hmm. Can you just unpick that a little bit for us? What is it in that is, really sticks out for you?
Yeah. So, the first for us really is sort of the soft signs of deterioration. So one of our big areas of work within LeDeR, and one of the things that we note is that we are spotting illness too late for people with a learning disability and autism. So they're very sick before we realise that something's wrong. Therefore, we're not really able to sort of suitably treat them in sort of the community safely. So we end up in A&E, and we usually end up in A&E via an ambulance. So it's about how important it is that our residential staff, our colleagues working in sort of social care as well, have the confidence, the training and the experience to be able to spot soft signs of deterioration early, because they're often non-specific. If you're working with someone with a learning disability and autism that's non-verbal, who isn't able to communicate, this is where it hurts, this is where I feel pain, I was up all night vomiting, I've got sort of diarrhea and vomiting.
Instead, you might just have more or less fewer vocalizations, or a different pitch of vocalization, or something less specific,
or potentially sort of lashing out. How the only way that person has to communicate sort of their pain is by behaviour which professionals may perceive as challenging. And it sort of leads into the whole, sort of diagnostic overshadowing. I mean, the reason why we popped in that, this gentleman has a flag on his address for a challenging behaviour is that automatically walking into that home, that is going to be in your head from a risk point of view.
Absolutely.
But no context, sort of no context that this gentleman has a learning disability, that there's additional needs there, that, not thinking, okay, so how am I going to adjust the way that I communicate and explain? All you're going in is thinking, I'm going to get smacked.
Yeah. And if you go in thinking defensively, it's going to be manifest in the way you interact with people.
Yeah, definitely. And, don't get me wrong, those things are important, part of risk assessing and is important for our safety, especially as, people that are maybe working outside of the, I say relative safety of a hospital. Any of those that have been
Only
in A&E
relative.
will understand the relatively of that point. But, you are working sort of out in the community, sort of very, very vulnerable. Even if you've got a first responder that's not on part of a 2-person team, you're on your own and you're working into someone's house. So, those risk assessments are important, but it's about sort of the context and how we manage that. And, that in this case could be missing, and it could, as you've said, impact how you go into that home and how you approach that person for the first time.
And then what about this kind of comorbidity of Prader-Willi syndrome and type 2 diabetes? What's significant about that?
So, well, I guess, and looking at our average, I mean, most people with a learning disability have one or more comorbidities. I think in Norfolk and Waveney, our report that is just coming out has shown that on average people have 4, comorbidities. Our gentleman here is, doesn't have, or you're not aware of all of his comorbidities,
sure.
Which is probably more
Maybe
likely.
No one's aware.
Yeah. But it's about recognizing that there's going to be lots of things going on. There's lots of management that goes into that person's health and well-being, and how is every piece of that puzzle being managed? Because if one part falls off, the rest is going to be impacted. If, the diabetes isn't being managed properly, and there is, how able is this person to self-manage? What is the support that they've got in place to help them manage if they are finding that difficult? And then how does that, their blood sugars and everything else impact on, their overall health experience?
So the ongoing care for Ali involving multiple different specialisms is just more intricate and I suppose more vulnerable to some kind of breakdown.
Yeah, because where is their care placed? I mean, they could have, so they've got their cardiology is at one hospital. They've got community dietetics, and they're also under the SALT team. But they're actually they've got quite a complex neurological condition, which is being met by a tertiary centre out of county. So they've got epilepsy. How is their epilepsy being impacted by the fact their diabetes is completely out of control? So all of these things, make a very, very complex picture.
Indeed.
So it's not just the one thing that you're walking into. They've got other aspects to their health that, you know, could be impacting what you're seeing.
And talking of walking into, so let's just progress with this case study. So on arrival, a support worker directs you to Ali's flat where he is agitated and pacing. A support worker does not accompany you, and Ali's flat looks cluttered and is difficult to access. He looks unkempt and he's pacing, appearing in pain and holding his stomach. He doesn't sound like he's having a very good day.
No. And what I guess I wanted to highlight there and what we've seen is the importance of familiar carers, someone that knows that person well to sort of support and, help that first impression, that first assessment, because otherwise you're walking into sort of, paramedics, you're often walking into an unknown situation with a person that can't answer your questions. But
that's really relevant, isn't it, to this case? Because this is a paramedic coming in. So how does that absence of familiarity of that professional, someone dressed in essentially a military uniform, you know, how's that? I mean, that's unnerving at the best of times. Let alone if you have a learning disability or autism, and you're already feeling a bit under the weather and apprehensive.
Does that person know that you've been called? Has the support worker called you without telling them that they've called you? Do they know who it is walking through the door? Again, you know, do they like, or are they afraid of people with uniforms? All of those things sort of need to be considered. What was the experience like
before?
Yeah, exactly. What has gone before to sort of inform that person's reaction to you as a healthcare professional. Again, sort of what I've mentioned, and, you know, many healthcare professionals working in the community would have seen this probably, you know, a living arrangement that is cluttered, you know, that is unkempt, they're unkempt. What is the situation there? And I think that's about, as you know, we all need to, is looking at the wider picture. You know, always have an eye on safeguarding. Always have an eye on the additional vulnerabilities that person has, and you know, that it needs to be constantly switched on. Sort of that switch on. You know, what am I seeing? What are the risks here? You know, what potentially onward referrals do I need to be making? Who do I need to be talking to?
Because there are actually quite useful tools, aren't there, for conducting clutter assessments to kind of quantify that level, because it is a safeguarding issue. It's a health and safety issue.
Yeah, definitely.
So folks should be thinking about that. As they're walking in. So should we move on?
Yep.
He's clearly in pain, so I wonder what was going to happen next. So it says that Ali's hard to engage and is resistant to having any observations taken, saying it is because he does not want to have to go and see the doctor or to go to hospital. He's pale and clammy and he looks to be breathing heavily. A colleague goes to find the support worker, who is able to give you a brief history, including his chronic constipation and recent attempts by the community learning disability dietitians to help him to lose a bit of weight. Ali's mum died 6 months ago, and she used to visit every week and supported him a lot with his health appointments. It appears that either his support workers have booked 2 recent appointments with his GP, but Ali didn't attend either. How common is that kind of a picture in your experience?
So, I mean, it's definitely common looking at the impact on someone's long-term health and well-being of having a parent carer still, you know, sort of involved and still around. Often we find that the best advocacy we see, you know, is from parent carers. You know, people with sort of a parent carer who are out there recognizing when they're not well, supporting them with cleaning, you know, supporting, you know, highlighting when something isn't right to the relevant health or social care professional.
Nobody can tell you to tidy your room like a parent.
No,
can tell you that, right?
Definitely not. But we really do sort of see a noticeable difference in someone that's living without that support as opposed to living with that support.
Sure.
And therefore, when you've got sort of an older person who has had a lot from, say, a parent, a mum or a dad, or any other sort of sibling, any sort of familiar carer, and they've suddenly lost that, You know,
it must be devastating.
It can be, you can see a very, very quick deterioration in keeping their house clean, following their daily sort of routine in regards to sort of showering, brushing their teeth, meeting healthcare appointments. I mean, that Ali maybe hasn't been to the GP on his own before. Mum's always gone with him. This is the first time that he's been unwell since Mum's died. And, the support workers booked the appointment expecting that, he'll know when that is, know how to get there, and then be able to get there independently. What we've seen is that actually he hasn't. So although we've maybe spotted that something's not quite right and he's unwell, we've made 2 doctor's appointments for him, but we haven't followed that through, either from the residential service side of you or through the GP. The GP's, okay, we've had 2 DNAs now from a young man who's always made his appointments before, and now suddenly we've got 2 times he hasn't attended, and we know that he's got a learning disability because he's on our learning disability register. Maybe we need to follow this up. Maybe we need to be contacting somebody. And it's about that professional curiosity. It's about going that one step further. And that is a reasonable adjustment. Going that one step further is a reasonable adjustment, understanding that additional help and support is needed to secure that access and to safeguard that person. So, and it's being aware that if somebody has lost that, if they've lost that advocate, that we need to be paying extra attention because things are going to get missed.
Sure. And what's the significance here of Ali's chronic constipation in the context of his existing kind of comorbidities?
So I guess this is sort of what's part of this case study is an awareness of certain syndromes that you'll see, which where people have a learning disability, and actually how those sort of comorbidities go together. So Prader-Willi syndrome often leads to overeating, sort of chronic overeating and chronic obesity. Prader-Willi also impacts the gut motility, so they've got a high risk of constipation, especially chronic constipation, and everything that can lead to. So
perhaps there's a risk of kind of almost perforation here.
Yeah. I mean, I guess I had this written in my mind is that he's got a bowel obstruction. He's sort of pale, clammy, sort of in pain, sort of breathing heavily. It's kind of what I had in my mind is that sort of there's likely a bowel obstruction. But what also needs noting is that he's resistant to having observations taken. You can see that he's not right. You've walked into that place. You know that he's in pain. You've spotted that he's in pain. He looks pale. He looks clammy. But he's not allowing you to take any observations. He doesn't know you. He doesn't trust you. He's obviously had incidences before. Maybe in a healthcare setting. Hospitals are horrible. For anybody. So you can see why someone would link, if you take me to a doctor, I'm going to have to go into hospital and I don't like hospital. And there where that immediate barrier comes in. No, don't touch me. Don't, because I don't want to go into hospital. That's all that sort of they see that end goal.
Sure.
Or, that end outcome. So now you've got, well, how do I get over this, sort of this hurdle? How do we get some observations so that which can support my clinical assessment and those sorts of bits.
Great, thank you. So fortunately, Ali's support worker helps to break the ice and gets him talking about a recent trip to Great Yarmouth Pleasure Beach because he really likes going on the ghost train. After some spending time, Ali consents to having his pulse taken, but not using a pulse oximeter. He actually listens to his chest, but continues to decline having his blood pressure taken or a finger prick to check his blood glucose. So I guess in that situation, we're back to this kind of reasonable adjustment, being adaptable, being flexible about the way that we approach this assessment.
And you aren't always going to get what you need, in any situation. From an assessment point of view, sometimes you need to, take what you can get and sort of make a best decision. I'm sure you've seen that, sort of in your clinical history. I can get He'll let me feel his, radial pulse. I can count his resps from just watching his chest rise. I can see what he looks like, but that's the best that I'm going to get, and I need to make a decision based on that. So
you've got to be pragmatic, haven't you?
Yeah,
you've got to be pragmatic sometimes, and this is as relevant to this is just as relevant to anybody as it is to the particular case of Ali here.
Yeah,
but perhaps especially so.
Yeah,
when actually you've just broke the ice.
Yeah.
You've just got a little bit of rapport going, and the last thing you want to do there is to overstep the trust that you might be building.
Yeah, because yes, it's easier to sort of put a SATS probe on and get your but actually, if they're happy to just have you sort of sit and sort of hold their wrist for sort of half an hour, hopefully not for half a minute while you're talking about sort of this, that, and the other. It's how you can get what you need sort of in the least distressing way. Thinking about sort of choice and capacity and, sort of deprivations of liberty and that sort of thing. It's about, how are you acting within, the confines of professionalism, really.
Yeah, exactly. Like, what is the least restrictive option in this situation? What can I do that, facilitates the greatest amount of autonomy without compromising too much on the good that I want to do in this situation? What is fair in this situation?
What's a win? A win in this situation is that, you're able to sort of, check a pulse, sort of check resps. That is the win. You don't have to sort of tick everything else on, tick everything off on the checklist.
No.
What's a win is that you're building a relationship.
Yeah.
You're building some element of trust because that this person needs to go to hospital.
Yeah, exactly.
There's an acute assessing. Yeah. So that is where you're going with this. So how can you build that relationship that, you're going to get Ali there?
Let's. I think this feeds really well into the last section. So, you're really worried about Ali's overall health, and you do want to take him to the emergency department for assessment, but he becomes really upset when you suggest this. You question if Ali really understands the consequences of refusing or declining the care that you want to provide, but you're finding it difficult to ascertain if he has the capacity to comprehend this. You're also unable to discharge Ali from your care for similar reasons. How many paramedics, probably in particular, but lots and lots of healthcare professionals have found themselves in this situation, challenging decisions around consent and capacity. Yeah. And that must be probably, again, perhaps another healthcare issue which is magnified in this patient group.
Yeah, no, definitely. And especially taking into the context, you're not in a hospital where you have a senior clinician that, you can, a consultant that you can call, or, you haven't got the capacity assessment specialist as part of the safeguarding team that you could bleep, or, you haven't got sort of a nurse in charge that you can go to. So you are very vulnerable, and it can feel very vulnerable in that environment to be, okay, I have to make this decision. I have to, make a plan here. And capacity assessments are, really a really difficult part of that, because often, you're doing it off the cuff. As the situation evolves, you're assessing, does this person have capacity? We do it every day. Whether they're, they've maybe, what their GCS score is, how much they're responding, how much am I going to have to make decisions on behalf of this person? So it's knowing what our responsibility is to the, capacity assessment and the Act and the law, but also the obligation that we owe that person, that whatever decision we are making, of course it's in their best interest, but we're taking as much of their voice and their viewpoint into that decision as possible. But also highlighting how difficult it is. I mean, it's a very difficult situation to be in.
These are the kinds of decisions and the kinds of situations that one can ruminate over.
Yeah, no,
Did I
definitely.
do the right thing?
Yeah.
Was that fair?
Yeah,
yeah.
And that reflective practice, I think, is really important in whatever role you're doing after you've maybe supported someone with a learning disability and autism. I mean, you mentioned earlier about, ways that students can, improve their practice and, support people better. And, part of it is about how you can help yourself. And, as much as whatever year you're in, I'm sure that, the idea of reflective practice has been repeated over and over and over. But honestly, it's so important. It's really, really important thinking, how did I manage that situation? In hindsight, without the adrenaline, without the worry, without the unknowns of what am I going to do and am I going to get this person the support they need, in a safer environment, having a think about how you managed it and how it could have been managed different is a really, really valuable tool.
And what you'll take from what went well to next time. Was there a way in which you interacted with Ali that actually, did you just stop and just totally chill and relax? You could see that Ali was poorly, but perhaps you spent some time just in the environment before you started trying to do anything kind of clinical.
Yeah, no, definitely. Yeah, just, taking that breath, reading the room and responding to what you're being given, sort of the communication that you're being given. Asking that question, when I move, will I say, first off, is there a specific way that I can sort of support communication? Do they have pecs? Do they really like social stories? Is there someone that they trust that can help me, sit with me, while I do this, assessment, while I ask them these things, all of those things. But as you said, what went well, that's just as important as what didn't go well. Because, you can share what went well, which helps build colleagues' practice, which, helps build the service and the quality that they're providing. So, yeah.
Okay, so that kind of brings our case study to a bit of a close. And I suppose one of the things we talked about was we really wanted to encourage anyone listening really to think about any previous interaction they've had with service users or people with autism and a learning disability, and to think about it in context of this case. What can you do to learn from what Andrew has kind of talked about from his experience, and what can you glean from those LeDeR reports to think about adjusting and just tweaking the practice that you have. So do give that some thought. We'd love you to give that some thought, and drop us a comment as well if you can, because it would be great to hear from you and your reflections on this podcast.
And it is, just around that, we mentioned earlier about how important the team is, but that is part of it. It's sharing practice with colleagues and, with your teams. I had this experience today, I did this and it worked really well. When your mate sees that in 2 weeks' time, it's going to flag something that, you might help them. So it is really, really valuable to sort of reflect and share your experiences.
Yeah, 100%. So I suppose we need to think about trying to sort of wrap this up a little bit. It's been brilliant, absolutely, talking to you. But I think if we could just maybe close on a last question for you, and that's, what do you think is the single way that any health or social care professional can promote the best possible outcomes for people with learning disabilities and autism?
I think bearing in mind the wide array of professionals and services, and how we see, how we treat, how we provide care for people, I think across the board the best thing that I could ask is for people to have that awareness and to be as best informed as they can about learning disability and autism, about reasonable adjustments and what constitutes a reasonable adjustment. And how you do that is, a variety of ways depending on how you, how you best learn. But I'd really encourage people to read sort of the LeDeR report that will be out in at the end of September. We do one every year, and Norfolk and Waveney's will be out. They do a regional one as well as also a national. The national team are a bit behind us as a region, so their 2022 report will be published later on in the year. They go sort of January to December, whereas all of the regions go financial year, obviously. Why wouldn't it be different?
Variety is the spice of the NHS.
So their 2022 report will be out, which again gives more of a national picture.
Sure.
But our regional one, I'd definitely encourage people to read it. It's got my contact details on, and I'm always open to a conversation about building reasonable adjustments within the service. That's part of my job.
So if students had ideas about quality improvement within their own part of the service, you'd like to hear from them?
Yeah. I mean, definitely. I mean, your senior members of staff want to hear from you. You are the people that are going to be designing quality improvement, projects in the future. Why not start now?
Yeah.
Everyone can be part of a organizational or a system change. Sometimes, more junior members of staff can feel a bit maybe disempowered, from making those real changes. But actually, you're the ones working on the front line. You're the ones that are out there sort of every day. You're the ones that see what is wrong and what makes your job more difficult and things more difficult for patients. So if you've got an idea, how can you share it? How can you improve that practice? You've really got to sort of be brave about, coming forward. And another part of that is, I think, around advocacy. It's being brave enough to be that advocate, because advocating is difficult at times. Whether it's because we're seeing something that isn't right, whether it's because we see that things need to improve, or we need to make sure that someone's voice is being heard. It can be really, really difficult to be an advocate, but it's a foundational part of what a health and social care professional does. So, being that advocate, I think, is really important. And, even if it's just, being their voice for someone that's maybe better informed, that can, put a very bespoke piece of personalised care together for them. But the advocacy is what got them there. So, being an advocate, definitely.
Thank you. What a perfect place to wrap this up.
No worries.
Andrew, thank you so much on behalf of the School of Health Sciences, and for everyone listening. That was really fascinating to get your insights and your input and your passion and your expertise. So thank you so much.
No worries. It's been a lot of fun. Thanks for having me.
Absolute pleasure. So thank you as well for joining us for this episode of HealthCast. We do hope you've enjoyed it. Do look out for further episodes, and we'll hope to see you on the next one. But until then, bye for now, and thanks very much.